Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hi, everyone. Welcome back to the Breast Cancer Podcast. I have Dr. Santosh Kale. He's a plastic surgeon that I work with, and he's here to talk about innovations in DIEP flap. Before we get to that, I'll just kind of talk about the different types of mastectomy. What is a mastectomy? Mastectomy is a surgery where we remove the breast tissue. And sometimes women will have reconstruction, sometimes they won't have reconstruction. When they don't have reconstruction, it's called a total mastectomy, where we remove the breast tissue and the nipple, and they just have a flat incision. They do have an option of delayed reconstruction. There's another type of mastectomy called a skin sparing mastectomy, where I stole this from Dr. Kale. He describes it as a pillow in a pillowcase, your breast being a pillow and a pillowcase. As breast surgeons, we remove the pillow and leave the pillowcase, meaning the skin. We also remove the nipple with the skin sparing mastectomy. And then he comes along and does reconstruction. And he's going to talk about that in just a second. The different type of mastectomy called nipple sparing mastectomy, where we leave the nipple and the skin. I remove the breast tissue. Dr. Kale and his team perform reconstruction. There's another type of mastectomy called a Goldilocks mastectomy, where it's a really great procedure for these women who are really large-breasted, and ptotic meaning drooping breast. If you have nursed kids, sometimes your breast can be really drooping. We use your skin to create a breast mound. And again, Dr. Kale and his team sometimes will perform reconstruction at the same setting or at a delayed time. Or if they're happy with the amount of the mound that they have, they may not get reconstruction. So, but I'm very happy to have you here, Dr.
Thanks for
Kale.
having me.
You're welcome. So I'm really excited to know what are some different types of reconstruction.
Yeah, so regardless of the type of mastectomy, patients who are interested in reconstruction, there are kind of two broad categories. The first is implant-based reconstruction. That means using an implant to reconstruct the breast after a mastectomy.
Okay.
So the implant replaces the breast tissue. And the other is autologous, also known as tissue-based reconstruction, where we're borrowing tissue from another part of the body. Those other places can be lower belly, thighs, buttock, lower back.
Wow.
We're borrowing that fatty tissue. It's transferred to the breast. That fatty tissue replaces the breast tissue to restore the breast after a mastectomy. And so that's the other broad category, is using your own tissues. So,
Okay.
yeah.
That's so great. I know I say this all the time. I feel so honored to work with Dr. Kale and his partners.
Likewise.
Yeah, thank
Yeah.
you, because it's a very unique thing to offer. And across the country, there's not too many plastic surgeons who do what they do. Just even offering just a deep reconstruction. I was diagnosed almost 10 years ago and had Dr. Kale's team perform reconstruction on me. And at that time, there were not too many plastic surgeons who are microsurgery trained, meaning they not only do their residency in plastic surgery, but they do a year fellowship in microsurgery. And that's what allows them to do this special type of reconstruction. Today, I want to focus on DIEP flaps. I want to know if there's any updates, any innovations in the DIEP flap space.
Yeah. So, as you know, the DIEP flap has been around for several decades.
By the way, what does that stand for
Yeah.
for our audience?
So DIEP stands for a Deep Inferior Epigastric Artery Perforator flap. So it's based on the blood vessels from the region which it's coming from. So
Okay.
when you're taking the tissue from the belly area, it's called a DIEP. When you're taking a tissue, give you another example, if you're taking the tissue from the buttock region, it's based on the gluteal artery arteries, so it's called gap flap.
Okay.
So, the principle of how it works is the same regardless of where you take the tissue from. There are just different names attached to it based on the blood vessels that are keeping that tissue alive in that region.
Oh, wow.
DIEP flap specific for taking the tissue from the belly region. Yeah.
Okay, that's awesome. So you're naming the procedure for where the blood vessels are coming from,
Correct.
essentially.
Correct. Yeah.
Okay, that's wonderful. What are some criteria for women to have a DIEP flap?
Yeah. So most people are candidates for having autologous or tissue-based reconstruction. Key things to consider is we want to make sure that someone's heart and lungs, that they're healthy enough to be able to tolerate a longer general anesthesia with the tissue-based reconstruction. We want to make sure that patients have enough extra tissue to give in order to reconstruct a breast to the size of their of what they desire. We want to make sure that there have not been other surgeries in those parts of the body, because sometimes those other surgeries can make those tissue no longer usable. So those are kind of the main things. And, when you meet with your surgeon, you can go over those things and, see if you're a good candidate. So.
For instance, if you had a colostomy on your abdomen, on your belly, you're probably not a candidate for that.
Right. Or some patients have had abdominoplasties before. So unfortunately, the belly tissue may not be usable at that point. Doesn't mean that other places are not usable, but for purposes of using the belly tissue, like that's no longer usable.
So abdominoplasty for audience is like a tummy tuck procedure.
Correct.
So if you have tummy tuck procedure, that actually essentially eliminates an option of having DIEP flap in the future. Actually, that is a really great point. I really don't know if women really know that as they are going into this procedure. So thank you for saying that. And as a breast surgeon, when I'm thinking of sending a patient to Dr. Kale and his partners to talk about different options for reconstruction, I very briefly talk about two different options: the implant-based reconstruction and the autologous, or you're using your own tissue type of reconstruction, specifically DIEP flap. And if someone needs radiation after surgery, after chemotherapy, or if someone has had radiation in the past, those guys really make it's a really good option to have.
Yeah, I would say the tissue-based surgery is more reliable in the setting of radiation. Now, it's not a one-size-fits-all type of thing. There are some patients that, even with radiation, they could potentially be good candidates for using implants. But, unfortunately, it's hard to make a general statement, because everybody's response to radiation is a little bit different. And therefore, what we can do after radiation also differs. But generally speaking, it's fair to say that, tissues can be more reliable in the setting of prior radiation. So.
That's also another great point. I will say we do talk about both types of reconstruction, but yes, and it is correct that they could have implant-based reconstruction if they've had radiation in the past or going to get radiation in the future. So that's really good to know. What are some risk factors, meaning what are some complications rather of this procedure?
Sure. So one thing I usually tell patients who I meet with for the first time is that there are common risks to all surgeries. What are those common risks? Those are things like infection, bleeding, wound healing complications. That's true no matter how big or small of a surgery you do, and that's definitely true for DIEP flap surgery. One thing that's specific to DIEP flap surgery is a blockage developing in the blood vessels that we reconnect. Now, in our group, the chance of that happening is less than 1%. We do a pretty large volume of these kinds of surgery on a weekly, monthly, yearly basis. So, that's something that we try to keep as low as possible.
Yeah.
Specific to the DIEP flap, which is taking the tissue from the belly region, one thing that the DIEP flap surgery does is that it preserves your rectus muscle. Your rectus muscle is that six-pack muscle that runs up and down from kind of like the upper part of your rib cage all the way down to the pubic bone. So we do have to, in order to do the DIEP flap surgery, we do have to either operate around or through the muscle. And one of the things that can happen is that muscle can get a little bit weak after surgery.
Okay.
So another risk, especially when we're doing a DIEP flap, is that muscle gets a little weak and there can be some bulging after surgery as well, too.
Yeah.
So those are the two big things specific to tissue-based surgery, specifically DIEP flap, that I tend to go over with my patients.
So flap loss, it's a common complication that you said you have less than 1%. And I know across the country, it's up to 5% chance of flap loss, the flap that they take from the belly to create a breast mound. And I know you talked about hernia, I imagine is what you're describing, like the bulging.
The bulging, right.
One other thing I had, and I don't know if you hear from the patients, is pain in the chest wall.
Sure.
Is that a common thing, like right where they connect the blood vessels on the chest?
Yeah. So, one thing you had asked earlier about innovations in DIEP flap surgery, and, I think one of the major innovations of the DIEP flap over the TRAM flap is that you save the muscle. In the process, regardless of whether you're doing a TRAM flap or a DIEP flap, when you move that tissue to the chest, you have to reconnect it to new blood vessels. You have to kind of plug it into its new anatomical outlet. And sort of in the past, a common way to expose the blood vessels that you reconnected to, which are the internal mammary vessels, which run sort of just on the outside of your sternum here, is you remove a small section of the cartilage of the rib. So it's probably about a 2 to 3 centimeter segment of cartilage. You remove that cartilage, and the reason it's removed is because you're able to then obtain access to the blood vessels that you have to reconnect the tissue to.
Yeah.
So for some patients, when you remove that section of cartilage, they can have some pain in their chest area. Generally, it gets better over time, but there can be some pain.
It wasn't terrible pain, but I do remember that.
Right.
And is there any other type of innovation in this case?
So, since we're talking about exposing the blood vessels, one thing that our group tries to do when possible is something called a rib-sparing DIEP flap. And so what a rib-sparing DIEP flap is we're able to identify those blood vessels without removing the cartilage. So you leave the rib intact. You're able to do the DIEP flap without removing that cartilaginous portion of the rib.
Okay.
Yeah.
Wow, that's very exciting. And does it take?
So if we look at this picture here,
okay.
One thing I want to show everybody is when you look at this picture, you can see the DIEP flap, right? And you see the fatty tissue from the belly here. You see the blood vessels as they travel through the muscle. They start from behind the muscle, they go through the muscle. As they travel through the muscle, they eventually go into the fatty tissue and they branch out. And that's what keeps the blood circulating both in and out of the tissue. That tissue is then transferred up to the chest, which you see the tissue that has been transferred. And what you see here is you see the blood vessels that of the flap reconnected to the blood vessels in the chest. And one thing I want to point out in this picture, you see the rib below and above. In a rib-sparing DIEP flap, that cartilaginous portion of the rib, that is preserved. So all we're doing is we're removing the muscle in between the rib to identify those blood vessels, to then reconnect to the flap, to reestablish blood flow into the flap, and then use that flap to reconstruct the breast.
That is really very cool.
Yeah, it's very cool.
That's really very cool. Yeah. So I imagine with this procedure, women will have less pain on the chest.
Yeah, the whole,
Yeah.
in theory, yes. And
Yeah.
we found that when we do deep flaps, I
Yeah.
would say anecdotally, yes, patients have less pain in the chest area.
Yeah.
I mean, there's still a lot that is going on in the chest that also contributes to the pain in that area. But yes, the idea would be to, one, decrease the amount of pain
Yeah.
in the chest area after surgery, but two, also to maintain the musculoskeletal integrity
Yeah.
so that musculoskeletal function is preserved. Now, it's not to say that when you remove the cartilage, that function is not preserved, but if we're able to leave the area as untouched as possible, we try our best to do that.
Okay. Wow, that's wonderful. So when patients are coming to you and asking you for this procedure or asking their surgeon for this procedure,
Right.
is there a way for you to say, yes, I can perform this procedure?
So that's tricky because, everybody's anatomy is a
Yeah.
little bit different.
Yeah.
Some people have a lot of space in between one rib and the rib below it,
Yeah.
or the rib above it. Some people have very little space in between.
Yeah.
So, I would say, unfortunately, I would love to do rib sparing deep flaps in for everybody, but unfortunately, it's not always the case that we can do that, especially if the space between one rib and the rib below is very small. That doesn't necessarily leave us a lot of room to be able to do the work that we need to do.
Yeah.
So when that space is large enough, then yes, we can save the rib. Unfortunately, it's difficult
Yeah.
to say at the time of the initial visit. It's one of those things that we're going to know when we're in the middle of surgery, when we can actually see with our own eyes, like what the space is between the two ribs and how everything's lining up spatially. So all those things sort of factor in. But, it is definitely on our radar as we're doing this, which is like, how can we, as best possible, save the rib?
Yeah.
Now, in some cases, we may not be able to save the rib, but we might be able to, instead of taking the entire cartilaginous segment of the rib, we take just a partial segment.
Okay.
So in some situations where we can't save the entire rib, then our fallback is to just remove a small segment of the rib, or the cartilage of the rib. But then if the space is really tight, then unfortunately we do have to remove the entirety of the rib so that we can successfully perform the deep flap. So,
wow, that's incredible. It's so good to know. I had not known about this procedure, so it's really good to know, to let our audience know about this latest procedure, so that they can talk to their surgeons, and I can see why it would be beneficial if they're able to undergo this procedure. And I 100% agree with you. Anatomy is so different. Every mastectomy, I feel like, is different in terms of the anatomy. And so I'm sure it's the same thing for you when you're doing the deep reconstruction. Anything else you want our viewers to know about this fascinating procedure?
I would just say, talk to your surgeon about this.
Yeah.
It's good to have the conversation about it.
Yeah.
And so yeah, I would say that would be the main thing.
Yeah.
So
Thank you so much,
well,
Dr.
thank
Kali,
you.
for
Appreciate
being
it.
here today to talking about this. And I got to learn something new, and I'm really excited. And our audience are so lucky to have you explain this procedure to them so they can advocate for themselves. So thank you so much.
Thank you very much.
All right. Until later. See you later.
See you.
Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice, so please talk to your medical professionals.